anesthesia, which was uneventful. On the day of the surgery, she was received awake with stable vital signs. She was induced with fentanyl, propofol, and rocuronium. Tracheal intubation was smooth and easy. After intubation, chest auscultation revealed almost no air entry. End-tidal carbon dioxide was noted to be low to absent. Esophageal intubation was considered. However, repeat laryngoscopy confirmed tracheal tube placement. Vital signs at this point were as follows. Bad ventilation was difficult to perform due to decrease in lung compliance. Thinking that the monitors were faulty, monitors and the anesthesia machine were changed. Repeat auscultation revealed tight air entry and wheezes. Vital signs noted at this point were as follows. Bronchospasm due to light anesthesia and exacerbation of asthma was considered. Sevoflurane was turned off and propofol was given. To correct the cardiovascular disturbances, epinephrine, hydrocortisone, and nebulization were done. The surgery was deferred and the patient was transferred to the intensive care unit intubated with the following vital signs. The symptoms of bronchospasm and subsequent desaturation are commonly seen in light anesthesia. Stage 2 anesthesia is characterized by uninhibited excitation, agitation, and breath holding. Reaction to noxious stimuli leading to laryngospasm and bronchospasm can be catastrophic. However, persistent hypotension, as seen in our patient, is unlikely. An acute asthma attack was entertained due to the signs and symptoms of bronchospasm, desaturation, wheezes, and the patient's history of bronchial asthma. However, hypotension is not part of the clinical picture of an exacerbation as well. Tension pneumothorax was entertained due to profound hypotension not commensurate with ongoing losses, tachycardia, and desaturation, which were all seen in our patient. However, post-operative chest x-ray proved otherwise. Hence, a possible allergy to one of our agents was considered. The patient was called up and was requested to do a follow-up visit to test for allergic anaphylaxis 6 weeks after the incident. With the patient's consent, intradermal testing for the drugs used during induction was done. Negative control used was normal saline solution, and the positive control used was morphine. The patient tested positive for rocuronium allergy after 15 minutes of administration. A high index of suspicion is required to clinch the diagnosis. While some reactions can be mild, anaphylaxis caused by neuromuscular blockers can occur within 5 minutes and can easily be confused with other more common anesthesia-related events, leading to delays in diagnosis. At best, supportive management is done during the resuscitative phase, and diagnosis is one of exclusion. The chronology of evolving clinical features is crucial to understand the pathophysiologic mechanism of an immediate hypersensitivity reaction. Drug-induced anaphylactic bronchospasm may occur either before or after instrumentation of the airway. Non-allergic bronchospasm occurs before airway instrumentation. These two pathologic mechanisms can be differentiated by the timing of cardiovascular events. Cardiovascular disturbance, a hallmark of severe IG-mediated anaphylaxis, occur within minutes after the administration of causative agent and is associated with followed by bronchospasm, particularly in patients with underlying airway hypersensitivity. The most common causes of perioperative anaphylaxis were antibiotics, followed by neuromuscular blocking agents, chlorhexidine, and patent blue dye. Among the neuromuscular blocking agents, rocuronium was the cause in 42% of the cases, and it occurs mostly in females with a ratio of 3:1, with 1% occurring after induction and within 5 minutes of administration. There are multiple grading systems that have been proposed for classifying the severity of the symptoms of anaphylaxis. The most recent proposed grading system from the study of Rose et al., as shown in this table, aims to aid anesthesiologists in giving appropriate treatment and make clinical decisions whether to continue with the procedure or abandon the surgery. Our patient had a grade B, life-threatening perioperative anaphylaxis due to persistent hypotension, tachycardia, and desaturation. Harper et al. Listed the most common clinical features of anaphylaxis shown in this table. Our hypotension, 46%, bronchospasm at 18%, tachycardia at 9.8%, and desaturation at 4.7%. This algorithm for testing allergy would help the anesthesiologist identify the causative agent. Much effort was exerted to obtain the consent for the skin testing of our patient. Once she agreed, intradermal tests of the drugs used were done. As expected, a positive test was elicited with rocuronium. This sealed the diagnosis as an associated anaphylactic reaction as the cause of her near-fatal crisis during induction. Despite the importance of anesthesia-related anaphylaxis, there is limited published data highlighting it. To date, there are only few large prospective studies of perioperative anaphylaxis. Since there is no specific predictive test to identify patients at risk for anaphylactic reaction, reduction of risk of anesthesia-related anaphylaxis can only be done by secondary prevention. Investigation of any suspected perioperative anaphylactic reaction is imperative to identify trigger agents and safe agents for future use. Thank you.